On. Okay. Well, here we are, and I am so wicked excited that everyone is joining us today for this really, really important webinar talking about the idea of trauma-informed care for the healthcare professional. When you come on, please introduce yourself and let me know where you're coming from. I'm going to give everybody welcome and share your name and where you're from. Post. Awesome sauce. Okay. So we're just going to wait a few minutes for folks to join. I hope the weather's nice where you guys are. It's nice here in Boston. We had a bit of a hot spell with extreme mugginess, never enjoyable. But now it's nice and sunny, and it is, dry. So it's really awesome. So folks are starting to join the room, which is really cool. And again, please let me know, share your name, where you're coming from. Once you check in, feel free to jot in any questions that you may have. As the webinar unfolds, I will try and respond to them promptly. If not, I will respond to them after the webinar, okay? I've also just posted a little information here about our Science and Soul 2019 Congress, which I'm so incredibly excited about. We had our inaugural event in February, this past February, in Bruges, Belgium. It was held at the Duke's Palace, the Hotel Duke's Palace, gorgeous setting. And we were so super honored to have Dr. Untitled Chapter as our U.S. keynote speaker and Dr. Rosario Monterosso from Northern Italy as our our European keynote speaker. And we were just overwhelmed with the information that was shared. Super dynamic, lots of awesome networking. We had, I want to say 14 countries represented, which was amazing for our inaugural event. And so we're going to do it again, and we're going to have it at the same venue, the Hotel Duke's Palace in Bruges, Belgium. It will be in February, the 21st to the 23rd. Our first congress was a 2-day event, and the participants really encouraged us to go with a 3-day format. So it's kind of like a 2.5-day format. Again, Dr. Untitled Chapter is going to be gracing us with her presence again, super blessed. And another physician from Siena, Italy, Dr. Carlo Bellini, will be our European keynote speaker. Dr. Bellini is a neonatologist, and he's also a bioethicist. And he's written some really awesome papers looking at the phenomenon of neonatal pain and some of the ethical dimensions of caring for the critically ill infant and managing their pain effectively. So just a super, super awesome lineup of speakers, both here in the U.S., North America, and Canada, as well as the EU. We've added 2 additional slots to 2 segments rather to our Congress. One is a spotlight series. And actually, we've got several amazing speakers, some from last year, going to be joining us for that segment. And then we've added a segment called Research in Trauma-Informed Care, where we've invited researchers to come and share what they're working on as it pertains to this concept of trauma-informed care and toxic stress in the newborn intensive care unit. So super cool event. You can visit the website, caringessentials.net, and then just click the conference, or click the button here on the screen. We are running our early bird registration, and it ends tomorrow at midnight. And so for folks that want to capitalize on the early bird, but may prefer to kind of put their payments over a longer period of time, this is the option for you. The early bird registration fee is $575. If you make a $75 deposit, then you will have the rest of the balance broken up into 4 installments of $125. So August, September, October, November. So you get the luxury of that while still getting the early bird registration. So check this out. It's also available on the website too, where you can find more information about the scientific program for the conference as well. We're doing this other really cool thing. I'll get right to my webinar, but I'm wicked excited about this. We're calling it Fireside Chat with the Expert. So we've got some pretty prominent speakers. And what we did is at the end of each of the days, set aside a chunk of time where the speakers will all be in these 3 different sitting areas. And it's just such a lovely hotel. You'll just be blown away. And the group will be assigned to a different room, and then the speakers will rotate between. So you'll get like a 20-minute additional, just talking to the experts, talking to Heidi Alves, talking to Dr. Bellini, talking to Thomas Kuhn, another neonatologist from Berlin who's going to be speaking, talking to Amy DeGatta, PhD researcher out of Rhode Island. Just wicked awesome face-to-face time with these guys, where you can pick their brain. And we've got other little activities to help really kind of support your goal to cultivate as much knowledge as you can, and also bring it back home, right? I mean, that's what it's all about. It's getting that information back home. So I'll leave this up for a little bit, and but get the show on the road with my webinar. It looks like we've got enough people here, and I certainly want to be mindful of your time. So the topic for today is trauma-informed care for the clinician, recognizing and rejuvenating the caring healer within. And I've talked about the idea of trauma-informed care for the clinician in the past, but this particular webinar, I really enjoyed pulling it together. It kind of was born out of the work that I'm doing for this really cool project for Carol Kenner for the Comprehensive Neonatal, I'm looking up the book up there, Comprehensive Neonatal Nursing Textbook is coming up with its, I believe it's 6th edition. And Amy DeGatta and myself have been invited to write an entire chapter about this concept of trauma-informed care in the NICU. And so, of course, we want to be very comprehensive with this content. We're introducing the science behind the concept for the infant, but also for the family and then for the clinician. And as I was fleshing out the bit for the clinician, I was drawn to this book that I've used in the past as a reference, but really dug in. I'm just reaching for the book now, not to be a total nerd, but it was written, it's 2009, but it's still incredibly relevant. It was written by this woman, Laura Vandernoot Lipsky. She's a social worker, and she talks about this idea of trauma stewardship. And as I started writing in the chapter, I thought, gee whiz, I was actually seeing some of my colleagues in some of the trauma exposure responses and thinking, no, but I don't think a lot of us know this. I mean, some people do, obviously, but I just felt like this was really important information. So rest assured at the end, if you'd like the slide deck, I'm happy to share the slide deck, and you will get 1 CEU for participating today. So without any further ado, let's get this show on the road. I love this quote. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. And we are immersed in suffering. We are immersed in loss. The work of the neonatal clinician and in nursing in particular, that is the core of what we do. We bear witness to the periods of humanity or human times that we are our most vulnerable, we are our most fragile, we are our most fearful. And as such, it calls forth the best version of ourselves to bear witness and ease the suffering of others. But as we do that, we don't recognize that oftentimes this also wears on our own soul. If we're not attentive to filling up our own cup and really managing our experience with this trauma and this tragedy, then we can also succumb to this concept of trauma, and we ourselves need trauma-informed care. And so my objectives for this webinar, is that you'll be able to define the concept of trauma stewardship as defined by Laura Lipsky. List 3 trauma exposure responses. To be truthful, Miss Lipsky has identified 16, and I'm going to take you through each one. And then I kind of want to ask you guys to kind of reflect on these. And have you seen any of this stuff in yourself, or have you seen this in others? And then at the end, we're going to just kind of talk a little bit about, well, what do we do about this? How do we help ourselves? And so that's this last objective. Identify one self-care strategy that you will commit to. Of course, I can't hold you to it, but I'm hoping, you know, I mean, generally folks that come to these are really committed to improving the experience of care for the patients and for themselves as well. So this idea of trauma stewardship, when I first saw this word, I thought, oh gosh, I mean, I hear the word stewardship bandied about. I really need to kind of come to grips and understand what the heck is stewardship. And so, of course, I looked it up because I'm a nerd. And according to the Merriam-Webster, stewardship is defined as the careful and responsible management of something entrusted to one's care. And I thought, okay, I think I get this. You know, many of you guys might be thinking, you know, this big initiative around antibiotic stewardship and infection stewardship and that sort of thing. And so the idea of trauma stewardship is then the careful and responsible management of the trauma exposure caring professionals experience in the course of their work. But before you can manage it, you have to know what the heck it is. What does it look like, you know? And so that's really where I'm going with this webinar. And here's a graphic. I hope it's not too much of a eye chat for you. But these are Dr. Lipsky's 16 trauma exposure responses. The way I've set up the slide deck is I've dedicated a slide to each one of these. I'm going to talk about it with you and invite you guys to share your comments, all right, as we go forward, okay? So thanks, guys, for saying hi, and I hope to have some more interaction as we progress with this presentation. So the first one I've seen a lot, and as I was reading about it, I could actually put names on this. It's that minimizing phenomenon that we do, and that is a trauma exposure response. Trauma exposure responses permeate every aspect of our lives, so it's important to understand what this is so that we can see not only when and where and why it's happening in our work environment, but is it actually happening in our life environment? And so minimizing from Lipsky is not triaging. It's not prioritizing. This coping strategy is at its worst when you've witnessed so much that you begin to downplay anything that doesn't fall into the most extreme category. And this second bullet was an example that I'd actually seen in the clinical setting where, we have parents in the care area, and there's a mom who has a late preterm baby. And the baby is, through our lens, right? We've seen this stuff, is going to be fine for the most part, right? They've got a little TTN. They're probably going to be in a hood for a couple of days, and then they'll probably go home, all good stuff. Sans any complications. And the mom is just hysterically weeping at the bedside. And I've heard several colleagues diminish her tragedy, her suffering, her fear and pain, and saying, well, gee whiz, what's she so upset about? At least her baby's not a 24-weeker. That's minimizing. You're starting to get a crispy crunch around the periphery when you start doing that. It's not a competition about whose pain and suffering is worse than someone else's. Pain and suffering, tragedy, is an individual experience. What may be tragic to me may not be tragic to you, but that doesn't demean my experience of the tragedy. And we have to be mindful of that. We have to watch ourselves and how we are responding to that. And so I want you to think about that. And as I said, this doesn't only happen at work. And, as a mom of, I had 6 children, and it was a hectic life having 6 children and working and all that other kind of business. I'm sure many of you guys can relate to that. And I would find myself getting frustrated with my children's, crying and fussiness about different things. You took a fall, and, this is a paraphrasing, but, stop being so dramatic. It's not like you're going to die, and I remember catching myself saying, if there's no blood, there's no worry, and these kinds of attitudes start to reveal to me, from my perspective, gee whiz, I was experiencing trauma exposure. you know, in the work that I was doing. And I think that really, I know that that's why I'm on the path that I am right now, because I was so traumatized by the work that I did. Loved it, but I needed to move to a different place because my soul couldn't take it anymore. And I want you guys to take a step back, you know, and think about, have you noticed this kind of behavior in either yourself or your colleagues? This minimizing the experience of another. And I'll be honest, I don't think that it's just relegated to healthcare professionals or caring professionals, you know, which encompasses much more than healthcare. It's, you know, firefighters, policemen, social workers, teachers, you know, defense lawyers, you know, all these people that serve others. You're more vulnerable for this. But I think even the general public, I think our society has actually kind of made us a little bit less warm, less connected, a little bit more cold. And that's a dangerous place to be. Would you agree? You know, I just, I was really struck by what it is that I'm seeing and reading in this material. And I think we need to share this with our colleagues. It's really important. Chronic fatigue. Hey from South Africa. Hey from Sunnybrook, Toronto. Hey, Marisa. Sammy, hi. Oh, this is awesome. The next trauma exposure response is this concept of chronic fatigue and or physical ailments. Now, I'm going to speak to you from my years and years and years of experience as a night nurse. And certainly working nights does already undermine your, you know, the level of energy that you have and stuff like that. But listen to this, you know, so that trauma exposure induces a level of fatigue that permeates every cell of your being. It's that bone tired, soul tired, heart tired kind of exhaustion that does not get alleviated with a good night's sleep. And her quote was, you see these fresh scrubbed and the hopeful idealism of new professionals, and I inserted nurse, starting out gradually gives way to that thrashed and haggard and martyred persona. Think about that statement within the context of where we are in the NICU, right? You see it. We actually can see these folks changing from that energized clinician to that person. And a lot of this, I think there's a response that I'm going to talk about in a little bit, actually gets hardwired into the culture of care, where the actual organizational culture is one that doesn't even recognize this. And so when you don't recognize it, right, you can't do anything about it. That's where you need to recognize before you can rejuvenate. Trauma produces an actual physiologic changes. And I know I go nuts about this with regards to the baby, but it happens to us as well. And the trauma exposure that we experience is superimposed on whatever trauma we've endured in our lives. What difficult challenges have we had? And again, it's not a competition. You may think, oh, well, this isn't as bad as something else. It doesn't matter. It's your experience. And how did it affect you? And how you responded to that experience informs how you will respond in future experiences and how you will interact with others who endure this. So I ask yourself, you know, how tired are you? What about those physical ailments? Working on nights, we had so many people had these really they weren't common types of ailments. Now, a lot of the common ailments that are associated with this level of chronic exhaustion or fatigue includes like migraines, hypertension, obesity. A lot of those chronic conditions that I talk about premature people being vulnerable to as they progress into adulthood. I want you to think about that. How well do you feel when you are working in these different shifts, floating back and forth? And I think a lot of us just tend to say, well, that's just what it is. That's just the nature of our work. And indeed that, you know, working difficult shifts and bearing witness to suffering is part of our work. But our responsibility to that work then is to rejuvenate ourselves, because our patients deserve our A game and we deserve our A game, right? So I'm hoping that we're stirring the pot and that there's some reflection going on here about, you know, all of these different types of exposures. Those feelings of helplessness and hopelessness seemed very, very concerning, if you will. And they arise when the positive aspects of our work are eclipsed by the negative, right? So the positive aspects of our work are, you know, easing the suffering of another individual, right? Being there and supporting a family in crisis. Those very special sacred moments where you know when you've had them, right? And we have them fairly often. However, they can get eclipsed by the organizational culture, our colleagues, bullying, a lack of self-care. And you just feel like, you know, it's just another day at the grind. And we've shifted from service to others to punching the clock and checking in and checking out. Is any of this resonating with you? Is any of this making you reflect on either yourself or your colleagues? Another trauma exposure response is a sense that one cannot do enough. If I don't do it, it's not going to get done. And if it doesn't get done, babies will die. I can never do enough. I know you've heard this. The belief that no matter what you do is not enough wreaks havoc in our lives, and it gives us a sense of inadequacy. And this is the bit that really is interconnected with the organizational culture. And if you've read any of the work about the professional practice environment, it's also that piece of it as well. That, you know, and this is definitely pervasive in the US. I think the UK also experiences this to some degree. Other folks, please chime in if you have similar experiences. But that thing like, we just never have enough. It's that scarcity mentality. We don't have enough staff. We don't have enough money. No, we can't buy that. You need to work harder. You need to do the work of 3 nurses, even though you're only 1. I hear this from my clin spec colleagues, you know, that they're managing 160 staff and they're the only person. And nights want them, days want them, other disciplines want them. They're getting pulled in 80 million directions. And what's our default setting? Our default setting is to rise to the occasion and perform and give. And that's admirable. But we owe it to ourselves to put boundaries in, because if we don't identify that this is, you know, this is not right, that there's not enough, it's not that I don't have enough, I have this. And you need to invest in more. If we don't draw the boundaries, nobody else is going to draw them for us. And so we need to take back our power and really be the ones to broadcast to the leadership. Now, as I say this, please know, I know it's not easy, okay? But there are strategies and tactics and resources that help build the case. That's a part of the work that I do with my Quantum Leap pioneers, is really helping them identify what their boundaries are, how to have those courageous conversations. It's about balancing the science and the soul of the work that we do to be that leader, to be that champion, if you will, for the unit and for your colleagues as well. So I want you to think about this, that do you ever have that sense that you can't do enough? These oppressive messages undermine our ability to recognize our own self-worth. And again, that was part of my experience, my clinical experience, is kind of losing that sense of validity, that sense of that good feeling that you have, that it was going away. And I basically just wanted to go and scoop ice cream for the rest of my life, because nobody died. Everybody had a smile on their face, and I didn't have to feel so bad all the time. And I don't want you guys to feel bad. You do amazing work, and we need to help each other continue to do that work. That's what the service that we offer is all about, right? Nurses care for that human experience. That's a noble calling. So we need to fill up our cup. But before we do that, we need to recognize what are those things then that are derailing us and undermining our full potential, our efficacy as that caring healer. Hypervigilance is another trauma exposure response reported by Lipsky. And it creates a dynamic. We are so focused on the work that we're unable to be present for anything else. And it kind of, it's intertwined with addiction, which is another one of the exposure responses. You know, that hypervigilance of you're always looking for something, something's always going to go wrong, that other shoe's going to fall. But it can really overwhelm us and detach us from being present to that caring experience with other. You know, when they say, when you're in a code, I never really did this, although I do see wisdom in it. Take your own pulse first, because when you take your own pulse, you're immediately brought to center. You're brought to the present, and then you can kind of then think more clear-headed. But if you're not able to pull in, you can just be kind of, all over the place, just not as effective as you could be. And I see that in some of my colleagues. And the reason why we shy away from pulling into center is we're afraid of the feelings that may bubble up and bubble over on us when we're in these moments. So we're always watching. We're watching out. We're watching out, but we're not watching in. Being present, though, allows us to self-regulate, right? We ask this of our babies, but do we ever think about our own selves being self-regulated? You can actually, by being present, being mindful in the moment, you can regulate your autonomic nervous system that then allows you to think clearly and act. And talking about this subject actually reminds me of the GRACE acronym. And I don't know how many of you guys have heard me talk about this before, but there's this really cool paper written by Joan Halifax, an American Zen Buddhist teacher, who worked with palliative care and end-of-life nurses that cared for adults. And she noticed that there was a high degree of compassion fatigue among these clinicians. And so, of course, her work is all about mindful meditation and being present. And so she created this acronym, GRACE, G-R-A-C-E, where the G is gather your attention. The R is recall your intention. And your intention isn't to check off all the boxes, all right? Your intention is to be with someone, to ease their suffering, to not make things worse for them, right? Recall your intention, G-R-A. A is attune. So attune to your patient. So I generally recommend you do the GRACE before you do your hands-on care, which I know can be hard to put the brakes on before you pop the doors and reach in and flip and strip. But just take a moment and activate GRACE. And attune to what is the baby doing? What's the patient doing? Are they sleeping? What state of sleep can you assess? That are they active? Are they quiet? Is this a good time to make your presence known? That C is consider your options based on your attunement. So do I go ahead in? Well, I really have to. Okay. If you really have to, then you open the doors quietly. You put your hands in on the patient on two non-vulnerable spots. Maybe the bottom of their extremities, cupped in your hand, and the crown of their head. And you give them a verbal greeting. And you give them some moments to just acclimate to your presence. That's the engage, E for the GRACE. But the GRACE has two E's. Then you proceed with your cares. You proceed with your cares based on the baby's tempo and ability to move with the cares along with you, okay? And then when you're finished, don't just shut the doors and take off. Come back to that hand placement in the two non-vulnerable areas and frame the care encounter. That helps the patient, but it also helps you terminate that caring engagement with that patient. If you were taking care of an adult, you wouldn't go in, just barge through maybe you would, but hopefully you won't. Barge into the door, flip their Johnny up, listen to their belly sounds, do whatever things that are warranted, throw the sheets back down and walk out of the room without any verbal engagement, would you? If you had that happen to you, you wouldn't tolerate it. So we have these ways that we can infuse our daily work that does help rejuvenate us, give us that sense of control, give us that sense of satisfaction that we really are that caring healer for our patient. But when you start seeing this hypervigilance, see it for yourself. You can see it in others as well, and recognize it as a trauma exposure response that needs some attention. So this next one I found really interesting, particularly within the context of the work that I'm super excited about doing, change, right? Changing culture. And I'm now kind of looking at the resistance to change through this trauma-informed lens, this trauma exposure lens. Decreased creativity is another trauma exposure response. The deeper we sink into a culture of trauma, the less flexible and original our thinking becomes. When you think about changing anything, you have to be creative, right? What's going to work? What's not going to work? How are we going to engage everybody? How are we going to make it fun, but still, get the numbers that we want? So there's creativity, but creativity there's always chaos involved, right? And if anybody's worked with me or you've worked with your own teams around changing culture, you know that there's some chaos, right? And that's why you test change first before you roll it out, which a lot of folks miss that step and they just say, let's do this and roll it out. But you want to test it first so that you can at least minimize the chaos, that the chaos is contained to your champion group. But it is that chaos that makes people feel threatened. And that's why when you roll something out without testing it and tweaking it, you escalate the degree of chaos and the degree of resistance and pushback that you're going to have, because your colleagues are, they're worn. They have been bearing witness. This is their trauma exposure response. And that resistance to change is really a coping mechanism to try and keep everything the same, because I can't take it anymore. There's just too much out of control. And at least this I can control, because you can't control the ups and downs of your patient. You can't control the ups and downs of the parents of these people, right? So what you're going to try and do is you're going to try and control everything else. And while I honor that as a coping mechanism, it's also a symptom of being a crispy critter, of really being on your last nerve. And we need to help rejuvenate that individual. And as I kind of mentioned earlier, I'm starting to think, like, is it possible that a culture of trauma may actually be contributing to this knowledge practice gap as we resist change to create a false sense of control? It's really an expression of our own internal turmoil that we're experiencing as a result of the trauma exposure responses. And so I'm going to invite you guys to start thinking super creatively about what can we do to change this. And it's not, I don't think it's a one size fits all. I mean, the one size would be mindful meditation or practicing presence, but there are other more creative things that we can do, I think, to help ourselves and help our colleagues. The next trauma exposure response is an inability to grasp complexity. So a strong indicator that you're experiencing this is when you start to look for clear signs of good or bad, right or wrong. You start thinking binary. You know, it's this or it's that. It's one way or the other. And we become less tolerant of those gray zones. All right. We become very judgy. We become so we all know, right, that family is a key critical component of the recovery of the fragile patients that we care for. And yet we also know that families have baggage. They have all this other kind of stuff that can be really overwhelming to us. And so we resist opportunities to integrate family into the workflow in a way to self-protect. I'm not trying to say that that's okay. It's okay. It's not okay. But that, I think, is why we do this. So we end up creating these rules, guidelines, policies that restrict, define when, where, and how a family is allowed to engage and parent their own hospitalized infant, because it's overwhelming to us. And we really are that outward expression of the organization that has failed to really put in and create the resources and the solutions that we need to help the patients and minimize our own overexertion from the trauma, overexposure from the trauma, if you will. Life is messy, but it's the messiness that really freaks us out. It makes it impossible for us to grasp. And so we just start looking at things binary. For example, substance use parents, individuals, babies that have NAS. It's very easy for us to say bad mother, bad father, bad parent, poor baby. It's easy. That makes it all easy. But is it really easy? Remember earlier when I said that our trauma exposure experience is built on our history of previous traumas that we've had. Well, these families, these substance use families and other families, any family, you don't have to have substance use to have had a traumatic history. If you remember the information I shared with you about the original ACE study, the Adverse Childhood Experience Study, 2/3 of the 17,000 people that participated in that survey reported one ACE. 87% reported more than one ACE. So we all have adversity in our childhood. We don't talk about it. It's the skeletons in our closet, but it has shaped how we walk through the world and how we deal with other people's traumas and challenges. We either have resilience or, we have a low threshold. And all of this kind of feeds into our vulnerability for these trauma exposure responses. Am I doing okay with you guys? Are you kind of getting where I'm coming from? practicing personal wholeness actually enables us to make room within ourselves to embrace the complexity of the human condition. And that's the rejuvenation piece, right? But again, you first have to recognize that there's a problem before you're ready to rejuvenate. You're ready to get on to the next, let me go up here, to the next phase in healing yourself. So my next trauma exposure is the inability to listen and or deliberately avoid. And avoidance creeps in as a regular habit where the highlight of your workday is not even doing your job. And so I'm going to give you an example of that. I mean, so when we do our patients up really quickly to avoid facilitating a parenting moment when we see the family coming in out of the corner of our eye, or we go through our cares really quickly and we think that that's really us being super efficient, when in fact, that just gives me 3 hours to put my feet up on the foot of the incubator and just chill out on the rocking chair until the next round of do-ups. That you're fried. You are having compassion fatigue. The inability to listen is also kind of another form of avoidance, right? It's avoiding engagement with others. And so we do that, and I've seen myself do this, you know, when someone's talking to me and I'm just like, I really don't want to engage with you. And so I either feign or I am busy, but, you know, I'm doing whatever, and then I give you just a curt response just to kind of make you end that. I don't really want to engage with you. And again, remember earlier I said, this stuff is not just relegated to our work. It creeps into our personal life. And people that do this, they find themselves going out less and less. And if they do go out, they want to go out with people who get it, right? Who are in the same boat as them. And again, I've seen that in myself, and I've certainly seen that in my colleagues. And so, you know, has avoidance crept into your daily routine? You know, just think about it. This is important self-healing stuff that I think all of our colleagues need to really be informed about. Disconnection and dissociative moments. And I talk about dissociation with the patients, right? When the patient is like getting an IV placed and 5 people have stuck the person and the person falls asleep. They did not fall asleep. They passed out. They dissociated. Their autonomic nervous system was so overwhelmed with what was happening to them. They removed themselves. They consciously removed their conscious being from that experience. That actually can happen to us as well. And it's normal for it to happen to people that bear witness to such challenging human experiences. It's a dissociative moment is you're engaged doing something, and then all of a sudden something becomes unhinged inside you and you're disconnected with what's happening in the moment. And the example that I came up with was, you know, if you're running a code and all of a sudden you just disconnect from the code and you're flooded with the memory of the last code that you did, and when it was an unsuccessful code, and you're lost in that moment. You've dissociated with it. And hopefully usually folks notice, they may not know that you've just dissociated, but they know something just happened and they'll move you out of the way and continue on. But these are normal occurrences, but the trick is to keep them from becoming problematic, you need to talk about them. I come from a long line. My husband jokes about it. And I'm we're in recovery with this, but of stuffing stuff down. Don't talk about it, because if you talk about it, you don't even know when you're going to stop crying. So just stuff it down, stuff it down, stuff it down. And we do that in the hard work that we do. I mean, sometimes we leak out some of it, but there's a lot of it that we've not resolved, we've not addressed. So no matter what role you play in the NICU, when you're exposed to suffering of others, you can expect these moments to occur. Notice them, but avoid isolation and seek out the support that you need. So I'm going to ask you guys, how does your unit support staff who've experienced the loss of a patient? Now, my experience is clean up the bed, you're on admits. But other units, and I know there are some units that have actual formal debriefings when a patient has died, for the clinicians and certainly for the family. But we need to process these feelings, and we need to process them together. Because if we don't, we're kind of suggesting that, well, we don't want to talk about it, they don't get talked about, and you just have to figure out how to deal with it. And we usually deal with it by stuffing it down. And that is not at all therapeutic. Debriefing on critical events in any facet of our life is crucial. I know there's some cultural stuff around that, but we really need to be mindful of what it is that we need. You know, have you experienced this? Have you experienced any of these dissociative moments? The next trauma exposure response is a sense of persecution. These feelings of persecution arise from a profound lack of self-efficacy in one's life. And we become convinced that we are unable to change our circumstances. And I hope that some of you guys are already thinking about situations where this is your reality. When we succumb to the belief that we cannot change our situation, we say, it's okay, we're going to just suffer, and we relinquish our power, and it becomes that martyr mentality. And that martyr mentality really, again, it can be an addiction in a way, all right? It's that idea of, have you heard about the golden handcuffs, where we feel like it's terrible here, it's awful here, but I can't leave because I won't get the same pay anywhere else. And so you've reduced your value and your worth as a human being to a dollar sign. And I get it, you know, you need to make a living, I get it. But where's the balance? Where is your worth, your peace of mind, your joy in life compared to a dollar sign? Balancing that up. Sometimes we feel even persecuted by our own patients. Why does this kid always need a new IV when I'm on? Why does their belly always blow up when I'm on shift? Why does this family always want a kangaroo when I have a busy assignment? And we just, live in that persecuted place. And when we do that, it's an insidious kind of a phenomenon, but what it does is it makes us lose sight of the prize, if you will. We forget that a baby fighting for his life and frightened parents take precedence over the work that we do. But when we do this persecution, we disconnect with that. And a lot of, this sense of persecution is actually operationalized in the language that we use in our work setting, right? I mean, like some of this, there was a really cool paper written by an adult physician who had a catastrophic intra-abdominal hemorrhage or something, almost died, and was in a coma, and heard clinicians saying, well, the patient tried to die, and all these other kinds of things that we just say. And it broke her heart. And it helped her realize, though, that we need to be very careful about the words that we choose, because the words that we choose really do influence what we tolerate and what we create in the environment. All right, so going on from persecution, I'm going to go to the next slide, which is talking about feelings of guilt. This was very interesting as the author wrote this with regards to her role as a social worker, and talked about how the work that she did was she focused on homeless people. And she always tried to dress down coming to work. She never wanted to share anything about her life because she felt guilty that she had a better life than many of her clients. And that can happen to us as well. Bearing witness to the suffering of infants and families we serve sometimes can make us feel guilty about the life that we have. Maybe our family is healthy and we have a great support network, and we can leave at the end of the shift where they can't. And so sometimes that really kind of creeps in and makes us feel like we have to squish it down and not show off. But when you do that, what you're doing is you're covering up your authenticity of who you really are. And in fact, when they've interviewed the homeless people, they said, no, we love hearing about your life, and it brings joy to us that there is joy out and beyond our own experience. It can be a distraction. It can be a source of connection and comfort with other when we actually engage in that way. Not in a pretentious way, but in an authentic way of sharing just human experiences. I hope that makes sense to you guys. Feelings of fear and fearfulness. I mean, fear is a natural response to much of what we witness, right? If somebody has a horrific diagnosis or a catastrophic event occurs, we do become fearful. But we also can sometimes have a fear of intense feelings, that what we're bearing witness to is so overwhelming that we're afraid that if we let any of our feelings out, it's just going to overwhelm us. When these feelings aren't addressed, they can actually turn into anger and prejudices when we're fearful. Fear can make us feel vulnerable, which can be uncomfortable. And when we are able to, however, acknowledge the fear that we have, it actually does deepen our compassion, our capacity for compassion for ourselves and for others. Because again, you're coming back to that authentic the common denominator across us and our patients and our colleagues is that we're all human. And so when we connect with each other in that way, it is therapeutic. It can rejuvenate. It can restore our sense of balance and a sense of, restore our sense of purpose. And then, of course, anger and cynicism. And anger is also a common feeling, as Lipsky says, among people trying to do the good work in the world. And we can get really frustrated in those things that thwart our efforts. It's important, though, for us to understand what does our anger look like, because a lot of times, at least for me, my anger just like blows up. I don't look at it. It's all these poor slobs that were just in my perimeter that get the hit of the anger. And it's important for me to see what it looks like, because when I see it, just like in recognizing the trauma exposures, then I can do something about it. In seeing my anger, then I can know what to do about it, right? It again brings me back to center, allows me to take my pulse. I can be present. Cynicism, however, has been defined as a sophisticated coping mechanism for dealing with anger, and it's witty and people laugh it off. However, what it does is it really warps our sense of the world around us. And I use this expression when I work with different folks about the normalization of deviant behavior in the NICU or healthcare in general. We just start thinking, hey, this is funny. And so funny makes us laugh. So laughing is good. But it's the vehicle that's making us laugh is actually warping our sense of the world around us. How else can when we might get angry at our patients for physiologic instability while we're doing cares. And then we can, then we say, oh yeah, you tried to die on us. But can you see that in saying that? No, the baby was not trying to die. But it's the words that actually detach us from our common denominator. And so I ask you guys, have you had bouts of anger and cynicism? Do you see cynicism in your work environment? And as you're recognizing these things, then that allows us to then reflect and identify rejuvenating strategies. An inability to empathize and feeling numb. And all of these, they're all intertwined, right? It's not like you have one or the other. You usually have this fusion of these trauma exposure responses. This inability is the result of a system that's completely overwhelmed. And I love the analogy of a sponge. When a sponge has reached its point of saturation, it can no longer absorb any more water. And that's us, right? I cannot take on any more bad stuff. I'm to the point of saturation. We become afraid to feel when we reach that point. And there was a lovely story in the book talking about this nurse manager who worked in a very busy environment where it's, you're on the go all the time, right? You're a total adrenaline junkie and you just don't even know. And she couldn't relax on vacation because the day-to-day structure that she had created that took her away from her inner self, right? So she didn't have to process any emotions that made her feel secure, if that makes any sense. But when she was away, all she could think about was the feelings that she was having inside, and she wasn't able to relax because she didn't know. She hadn't learned how to process those emotions. They didn't have a routine for debriefing or any kind of self-care resources on the job, or she hadn't built any at home as well. So that's kind of what that's all about, if that hopefully makes some sense to you guys. This next one, although I did use the golden handcuffs example before, but addictions, it's an attachment so strong that it persists despite our understanding of the potentially destructive nature. And so usually when people think about addictions, they think about alcohol, drugs, food, and sex. There are many other types of addictions, all right? But overwork also is an example of an addiction. And I used to always pick up shifts, and I could rationalize why I needed to pick up the shifts. But it kept me away from feeling and being who I really could have been, and that's why life is so cool, right? Because you have these experiences, you can reflect and you can learn, but to be cautious of these addictions because they're insidious, they sneak up on you, and it seems so noble that I'm going to pick up that extra shift because you're short-staffed. It's so lovely. It's so wonderful. Isn't she the best? So I get that little dopamine burst, but it also keeps me away from dealing with my real world, my real life, because I'm running out of here. I mean, at some point, the efforts to escape these feelings associated with our work are unable to be held back by our addictions, and you generally break. And I don't know if any of you guys have had an experience where you've seen, someone break, and it's challenging. It's challenging for the individual, and it's challenging for you as well to be there for them when they are, again, profoundly vulnerable. So, just ask the question right now: what are you most attached to? Is it crossing the line? How does this attachment, whatever it is, serve you and your world, and you're bigger than your world. All right. You're bigger than being a nurse, a therapist, a doctor. Which brings me to the final trauma exposure response. A grandiose perception of self, or an inflated sense of self-importance related to one's work. When work becomes the center of our identity, it may be because it feeds our sense of grandiosity. And we, particularly here in the United States, struggle with this particular trauma exposure response because it's so pervasive in our culture that we are defined by what we do. I mean, when somebody says, "Oh, hey, we don't, so I want to get to know you," what are the first things that we say? "I'm a nurse." And we feel like in that sentence, that's all you need to know. That's it. That's me in a nutshell. Gee willikers, right? I mean, losing ourselves to our work really means we've lost ourselves. We are more than a nurse. We're more than a mother, a father, a brother, a sister, a friend, a jogger, a swimmer, an artist, right? We're all of that and much, much more. We're greater than the sum of our parts. Maintaining a sense of balance between all the facets of who we are enables us to preserve our wholeness and our sense of self-integrity. And that's what, again, will help us on this road to recovery of becoming that caring healer that we chose to be way back. Maybe it's a year back, 3 years back, 30 years back, right? So I invite you guys, what you do is not who you are, right? I mean, I know it's easy to say I'm a nurse and then I don't have to talk anymore because I want to avoid, because I can't engage because I'm so tapped and I have no more energy left. If that's our, we have to approach this with caution, to rely on our work for our sense of self-esteem. You may be the greatest nurse on the planet, but you're still greater than that. You may be the greatest therapist, physician, whatever your discipline is. You may be the greatest in the world, but you're better than even that in your own eyes and in the eyes of others. That beautiful saying that, oh gosh, am I going to mess it up? To the world, you may be one person, but to one person, you may be the world. And it's not in your technical skills that you are the world to other. It is in the way that you provide comfort, a sense of safety, connection, security, all that really important stuff. So to just kind of recap all of this, and meet my objectives, and then I just want to post up this other little bit here that I'll talk about briefly. Trauma stewardship and the concept of trauma-informed care in the NICU have implications for the infant and family and for ourselves. And I will share this slide deck with you. And I have the references there if you're interested in getting the book. It's awesome. Bearing witness is a moral way of engaging with our patients and their families. That's by NAIF. And we must be cognizant of the toll it takes on us and adopt self-care practices that help us find balance, create a sense of personal control, and make healthy lifestyle choices, making sure that we have a supportive social network. Those are the rejuvenating prescriptions, but how you fill that prescription is individual, right? Let's see, finding balance, creating a sense of personal control. What can you control and what can you let go of? What can you, and it's really hard because I'm like a recovering control freak and I still have my lapses. But being mindful really has helped me progress and advance in or relinquish rather, my control freakiness bit. This idea that the onset of trauma exposure responses is insidious, as I've said, and even invisible in settings that lack an awareness about the physiologic and psychologic sequela of bearing witness to the suffering on a regular basis. Remember, I talked about that HPA axis, chronic exposure to toxic stress. It has a cumulative effect on our patients, our families, and ourselves as well. This idea of trauma stewardship is really aimed at mitigating these deleterious effects. When you're trauma informed, right, then you can then take action. So this piece of the trauma informed component for clinicians is being able to recognize trauma exposure, your responses to trauma exposure. And then in recognizing that, then you can see I need to fill my cup up, because my cup is not, it's almost empty. Maybe it is empty, I love how Nave talks about this moral way of engaging with our patients, but being cognizant that we need to fill up our cup. And I'm going to end on this. I'm going to share some more, but end on this really cool quote from Gene Watson's most recent book. I'm such a nerd, and I don't think I have it down here to show you. But I love Gene Watson, love Florence Nightingale, love that stuff. And she talks about how if nursing continues on the trajectory of just being obsessed with checking off the boxes and being the most technically proficient person in the room, we're actually going to divorce ourselves from the primacy of what it is that our profession is all about, right? And become these, advanced technicians, but we'll end up getting absorbed into other disciplines. We need to own and honor our calling of not only bearing witness and engaging in a moral way with our patients, but subsequently managing them, supporting and managing their human experience, their individual experience with their disease, with their hospital experience. And Watson, then kind of says how one is with oneself affects how one is with others, and vice versa. How one is with others affects how one is with oneself. And so think about, how hard are you on yourself? Do you beat yourself up about not getting the IV, or making peanut butter sandwiches every day for 7 days? Or, do you beat yourself up? If you beat yourself up, you're going to beat other people up. That may not be your intention, but it becomes your default setting. And it's all a result of you just being burnt out. Is one thing. It's compassion fatigue. It's trauma exposure. And so again, recognizing this allows us to think about strategies to rejuvenate ourselves and restore that caring healer that resides within us. One of the ways that we do that is through meditation, through yoga, through exercise, making good diet choices. And you don't have to make a good diet choice every day, but it's moving towards it. The one thing, I had a call this morning with a colleague of mine who is my partner for the Quantum Leap program. She's the soul coach. And I was saying, at one point I thought I was just like, the place that I had to get to was a destination. And then I would be all set and everything would be easier and I'd have more wisdom and all this other kind of stuff. And then as I've been on this journey, I've discovered that there is no destination. It's all about the journey. And it's all about learning more and more about yourself that helps you improve yourself. It's a continuous quality improvement for who you are and cultivating that A game over time. I don't have my A game on every day, every minute, every hour, right? Nobody does, but I strive to. And it's in that striving that I think brings me a sense of joy and makes me effective in service to other. And that's what I invite you guys to do. And the first thing to do is to take your pulse. Take your pulse and see, where do you fall along these trauma exposure responses? And then create that self-care prescription. Commit to one thing. Every morning I get up, this is the truth, every morning I get up, the alarm rings at 5, I roll out of bed after 2 snoozes, snooze alarms, and I walk my dog. And that is my time to just connect and set my intention for the day and because I don't know what the day is going to bring, you know, that's a little thing to do. And I try and add on other things. I waffle with the yoga. I try and do these different things. But one of the other things I do is I'm thirsty for knowledge. That fills my cup up. I discover now that there is no end to what a person can learn and know. And so that's another way. And I know that that works for you guys too, because you come to these webinars for continuing education to impart more knowledge and wisdom so that you can share it with your friends, your colleagues, and your patients. So, you know, as an education thing, I'm doing lots of different education things. I really need to hear from you guys. What do you need? How do I present it to you? How do I package it in a way that's accessible, that's relevant, that fills your cup up, both heart and soul and brain? This particular cup filler upper is a wicked cool course that I'm offering at Summerlin Hospital in Las Vegas, Nevada, August 10th, 11th, and 12th. It's a master class, and a master class is basically someone who knows what they're talking about, which is me for this subject, neuroprotective care, trauma-informed neuroprotective care, doing a lot of engaging, interactive education, problem solving, troubleshooting across each of the core measures to give you a package and strategies that you can take home and operationalize in your NICU. There's some short-term quick fixes and some longer-term fixes. But the other cool thing about this is it's the networking and identifying accountability buddies that you will then network with, you know, beyond the workshop. You know, as you're working with your on your project, you have other folks that you can reach out to who are on the same journey. And, you know, what do they say? But the more minds are better. I'm so sorry. My brain's working faster than my mouth. The program, the special offer that I wanted to offer for you guys though is for being part of this webinar and joining me and spending this hour. And even if you're listening to the replay, if you submit a $47 deposit, it's $297 for the 3 days. It's $130 for 1 day. And you can check the website and get the agenda for each day if you want to do the 1 day. If you submit a $47 deposit, I'll take it off of the tuition for either way. But you'll also then get a downloadable recording of the opening speaker at our 2018 Science and Soul Conference, Dr. Marilyn Sanders, brilliant physician, clinician, and human being who talks about trauma-informed care, promoting a sense of safety, security, and connectedness. She's also published an open access paper that you can also, I'll give you the link to. I mean, it's open access, but I'll put the link that as well if you are interested in taking advantage of this special offer. So the offer expires tomorrow at midnight is the last day, July 31st, as is for the early bird registration installment plan for Science and Soul. So please visit my website. And, you know, and ask me any questions. You know, I'm obsessed about questions, and I always want to make sure that I'm providing information that's clinically relevant and appropriate for you guys. I don't have the references on the uploaded one for this, but on the handout, if you're interested, I do have the references for all of you nerds out there that want to buy some books and download some articles. Again, here's my email address. If you have any questions, shoot me an email. Check out the website. I hope, you know, I look forward to taking, you know, hearing from you guys and serving you in a way that's clinically relevant and also relevant for your soul, right? To really help you be the best version of yourselves in service to others. That's, I think, what we're all here for. This is our heart-centered calling and our purpose and our passion. So I'll stop blustering along and say farewell. And as always, take care and care well. Bye. You can throw a question up there or I'll just sign off. All right, you guys have a great rest of the day and a great week. Bye-bye.